So thanks again for joining us for tonight's discussion about heart failure. This presentation will talk about what heart failure is, how to recognize the symptoms of heart failure, as well as discussing prevention recommendations, treatment options, and more. And now I'd like to introduce you all to our speaker this evening, Dr. Hakim Uqdah, a fellowship-trained cardiologist at Ascension St. Agnes Heart Care. Dr. Uqdah completed his cardiovascular disease fellowship at Penn State Hershey Medical Center in Hershey, PA, where he served as chief fellow. Dr. Uqdah is board certified in clinical cardiology, echocardiography, and nuclear cardiology. He has a special interest in echocardiography and treating hypertension, as well as heart failure and cholesterol management, and he is passionate about improving healthcare disparities. Dr. Uqdah, thanks for joining us tonight. Welcome.
Thank you, Kelly. I appreciate it. I want to welcome everybody to tonight's seminar. As Kelly mentioned, I'm Dr. Uqdah. I'm a cardiologist at Ascension St. Agnes. I had an opportunity last year to speak about hypertension or high blood pressure, and we want to piggyback on that and introduce everybody to understanding heart failure. So tonight's objectives, we're going to discuss what is heart failure, understand the types and causes of heart failure, the signs and symptoms of heart failure, how we diagnose heart failure, and treatment options and prevention recommendations. And we'll also discuss the role that cardiologists play when managing heart failure. As Kelly mentioned, this discussion is meant to be interactive as well. So we will pause for questions midway through the presentation and then have a Q&A session afterwards. So what is heart failure? Essentially, it's failure of the heart to fill or pump blood. Um, this, you may see terms such as congestive heart failure, systolic heart failure, and what that means is that has to do with the pumping of the blood. So systolic heart failure, it's a medical term that stands for a weak heart or a heart that cannot efficiently or effectively pump blood. You may also see the term HFrEF or HFrEF, or you may see that written on some of your documentation, and they are all synonyms for the systolic heart failure or weak heart failure. Then there's another type of heart failure called diastolic heart failure. And this heart failure, this type is characterized by a stiff heart. While the heart can pump blood, it is very stiff, so the heart cannot fill properly, and that leads to the same result. You have very limited blood and oxygen to your vital organs. Another term that you may see is cardiomyopathy. The cardio stands for heart, and the myopathy stands for heart dysfunction or a weak heart. Why is it important to understand heart failure? Well, it's a very common condition. About 6 million Americans are currently living with heart failure. And a third of the adult population in the US is at risk for heart failure. The overall lifetime risk is about 1 in 4 or 24%. It is also the most common reason for hospitalizations in older adults or adults over the age of 65. We see a lot of heart failure when we're in the hospital, and it's a very common condition that we treat in the hospital as well as in the office. The proportion of younger patients who are being diagnosed with heart failure is increasing, and this is as compared to our older patients. So that's also a concern. The rates of heart failure are higher among Black and Hispanic individuals, and not only are they higher, but Black patients in particular, younger patients that are African American, tend to do worse, meaning that they tend to have a higher number of deaths due to heart failure, and that number has been on the rise over the last several years. Additionally, higher death rates are seen in Native Americans as well as Alaskan Natives. We also have seen the increase in hospitalizations, as mentioned previously. I just want to show an illustration of what a normal heart looks like. This is the heart kind of sliced in half, and we have four major chambers. The first is the top chambers, and we call these the atria. And this is the right side of the heart, and this is the left side. The right side of the heart receives blood from the body, and then this blood will be pumped towards the lungs so that we can receive oxygen, and then it comes back on the left side in the top chamber, then down to the bottom chamber, and then the heart pumps that blood out to the rest of the body, and that's the red that you see. So the red blood is the blood that carries oxygen to the rest of the body. The blue blood is the blood that has been returned to the heart so that it can be oxygenated or receive oxygen from the lungs, and then we can pump it out to the rest of the body. Here's another illustration. On the left side, we have what a normal heart should look like. We have the two top heart chambers, like I mentioned before, and the two bottom heart chambers. Again, the bottom chambers are the pumping chambers. They pump blood. The right side pumps blood to the lungs, as mentioned previously, and the left bottom chamber, or the left ventricle, as we call them, pumps blood to the rest of the body. So the top chambers are called the atria, the bottom chambers are called the ventricles, and the bottom chambers are the main pumping chambers of the heart. When somebody is diagnosed with heart failure, this is an illustration of what a weak heart would look like. The heart is often enlarged or dilated, and the muscle becomes very thin. If you look here and you compare it to the normal muscle on a normal heart, the muscle is very thin and weak, and the chamber has now increased. This combination of enlarged and weak heart makes for a very inefficient pump. So the heart now pumps weaker, and that's less blood to our organs. Another illustration, this is now the heart. We're seeing it from the outside, and we kind of see the arteries that feed the heart. So on the left side, again, that's a typical normal heart. And on the right side, this is an enlarged heart. So the dotted lines represent the size of a normal heart. And now the heart is enlarged, and this also leads to a weak heart. I want to show an illustration. This is an illustration of a normal heart right there. Normal heart, as the heart gets weak, it enlarges. And the squeeze or the pump is now weaker. And then there's some backflow of blood to the top chambers, which is not a good thing. This video will play a couple times. So now the heart is even more weak and larger and more dilated. And as you can see, not much blood is being pumped out into the main artery of the body. And there's more leaky blood. So again, this is going to be a picture. First, this is normal, nice squeeze. And then the heart enlarges and it becomes weaker. And if that process continues, the heart will become more enlarged and more weak, and patients will tend to have more symptoms. And we'll talk about that in a second. This is an illustration of the stiff heart. So again, this is what we call a cross section, or the heart basically sliced open in half. And as I mentioned, we have four chambers: the top, which are called the atria, the bottom, which are called the ventricles, the bottom are the pumps. This here that you see, my arrow is pointing to the heart muscle. So a heart with a very stiff heart, the heart pumps normally or even higher than normal, but it's so stiff that it cannot receive blood efficiently. So the blood backs up because the heart chamber is small, there's less space, and not much room for the blood to travel into the bottom chamber. So that leads to very similar symptoms, albeit it's from a different cause, but it leads to some of the same results. In this presentation, we're going to focus mostly on the weak heart, the systolic heart failure. So what are some of the causes of systolic heart failure? Number one in our country would be coronary artery disease, otherwise known as narrowing of the heart arteries. This can be seen when people have severe narrowing of all their major arteries or a majority of their major arteries, or a prior heart attack, which has now led to weakened heart muscle because the artery was completely blocked. Coming in at number two would be high blood pressure or hypertension. That is a very common cause of systolic heart failure. It's actually the most common cause in African Americans. So in our entire country, coronary artery disease is number one, but in African Americans, high blood pressure is number one. There's also a lot of other conditions such as heart rhythm disorders. There's heart valve disorders. There's toxins to the heart, such as alcohol, cocaine, chemotherapy. Even stress can cause heart failure. There's a very particular syndrome that we call stress-induced heart failure. And that's due to different types of stress, but it's a very well-known entity. Inflammation can lead to heart failure. Certain viruses can lead to heart failure. There's also women who are in the late stages of pregnancy and even until after birth can have a very specific disorder leading to heart failure related to pregnancy. And then heart failure can be run in a family. So it can be genetic or familial, as we call it, meaning that this is something that has been passed down through DNA from generation to generation. And that is treated similarly, but we also see that those types of heart failure at earlier ages. Heart failure, like I mentioned before, is a condition that causes the muscle in the heart wall to slowly weaken and enlarge, preventing the heart from pumping enough blood. And this, again, is the same example that I showed previously. It's an enlarged and weakened muscle. So what are the risk factors for heart failure? As I mentioned on a previous slide, some of the causes are the same as the risk factors. So you can have high blood pressure, but not have heart failure. So that's a risk factor. You can have heart rhythm disorders, um, that does not cause heart failure, but it's still a risk factor. So the causes are also risk factors. In addition to the risk factors that we previously discussed on a prior slide, as we get older, that's a risk factor for heart failure. Tobacco is a risk factor. High cholesterol, obesity, diabetes, all very common things. Sleep apnea, heart defects from birth can be a cause for heart failure, and certain medications. Now, what are the classic or typical symptoms of a patient that has heart failure? Well, one of the cardinal or one of the main symptoms would be shortness of breath. And it's really shortness of breath, especially when performing activities or when laying down. So when you're lying down, basically gravity has been eliminated and blood, if it can't move forward, it goes backwards. And when you lay down, that blood can then back up into the lungs, and then people will feel short of breath because of that. Feeling weak or tired, that's another very common symptom. We call that fatigue. Coughing, that's another sign. It could be a sign, a symptom of heart failure. Weight gain from fluid buildup is a very common occurrence. And then swelling goes along with that in feet, the ankles, and legs. And again, that has to do with gravity because we're usually upright during the day. The swelling or the fluid will go to the dependent areas of the bodies, which is in the legs. It can also lead to trouble thinking or confusion. You're just not thinking as quickly as you are used to, and that has to do with the lack of blood supply and oxygen to your brain. That same fluid buildup can happen in the belly, and that can lead to the liver being enlarged, and that can lead to nausea as well as a lack of appetite. So just not feeling well overall. So these are not the only symptoms, but these are very common symptoms of heart failure. So let's pause right here and take a break and see if there are any questions thus far.
Yes, we do have some questions. First up, can heart failure or an enlarged heart be restored or reversed to back to a normal heart?
Yes, we're going to talk about that in some of the subsequent slides, but yes, we have treatment and we do rely heavily on certain medications that we know can kind of slow the process to a point where people feel better. That's most importantly. The second thing is that it can reverse or halt the process that is going on with heart failure. It can limit people or prevent people from needing to be hospitalized. And one important thing is people live longer lives. And also, we do see that the pump sometimes improves with those medications as well. We like to treat the underlying cause of the heart failure because when we treat that, that has a higher success rate or chance of restoring normal heart function.
Fantastic. At what age should a person consider getting a baseline echocardiogram? And is there a certain check-in, a subsequent frequency after that?
Well, you really do not recommend screen and echocardiograms for just everybody. Usually we do that based off symptoms or based off of your family history. So if there is a family history of something that we think may run in the family, at that point we will recommend echocardiograms in some people starting from childhood, depending on the time of diagnosis of their family member. But outside of the familial or genetic versions, it's really based off of symptoms.
Okay, great. Could you tell us what a bundle block is?
A bundle branch block has to do with the electrical activity of the heart. So the heart has a natural electrical pathway. And with a bundle branch block, that pathway can be blocked when it gets down to the pumping chambers, which is the ventricles, and it leads to dysynchrony, meaning that the heart usually pumps the same time. The top chambers will pump and the bottom chambers will then pump. The bundle branch block happens where the bottom chambers pump at different times. They are not in unison.
Okay,
That
perfect.
itself can lead to congestive heart failure in some people. So that's an excellent question.
Great, thank you. How dangerous is an aortic dilation?
Aortic dilation is a different topic. Um, If it gets severely dilated, it can be dangerous in terms of the stretch. That's that big blood vessel that the heart pumps into. That it's different from what this topic is tonight, but it can be dangerous if it's severely enlarged. Most people, we kind of follow that with different testing, such as an echocardiogram or a CAT scan or an MRI, but though it's different numbers based off of different patients. Um, Hopefully we can have a discussion on that at some point in the future.
Perfect. Yeah, sounds like a good topic. What kinds of medications or categories of medicines are risk factors for heart failure?
So a big class of medications that are very common would be your anti-inflammatories. So if people take lots of Aleve or Motrin or ibuprofen, they can lead to a lot of fluid retention, and that itself can lead to extra fluid and may make it hard for the heart to pump. There's also medications that can weaken the heart. So certain chemotherapy agents have been known to weaken the heart if they're used in higher doses. So those are two classes of medications that can lead to issues with the heart.
Perfect. Um, could you describe what a heart murmur is and if that's related to heart failure?
Heart murmur can be related to heart failure, but the simplest way of explaining a heart murmur, it is a sound that we hear with our stethoscopes in the simplest terms. That sound can be related to lots of different things. That could be, some people are born with a heart murmur, and it's something that's just unique to them, the way the blood moves to the heart. We can just hear it. There's other people that, if you have congestive heart failure and you then develop a leaky heart valve, like we saw on that one animation where the blood is now going backwards, that can produce a heart murmur, and that heart murmur is from the leaky or the backflow of one of the heart valves. So a heart murmur is just a description of what we can hear with the stethoscope, but there's many different reasons or causes of a heart murmur. And yes, it can be related to heart failure, but there's plenty other conditions that can cause a heart murmur that's not related to heart failure.
Okay, perfect. Um, and just to backtrack to the previous question about medications, can you clarify, is long use of anti-inflammatories a cause of heart disease, or is it just or like a contributing factor? And
I
what would
would
you
say
consider long use?
yep, if you have congestive heart failure, using we advise not to use those medications because of what it can do to salt and water retention. I would say they themselves do not cause heart failure, but they can make heart failure symptoms worse. The use of anti-inflammatory agents. So in terms of there are certain medications that have been known to cause heart failure. Those would be more of, like I mentioned, the chemotherapy agents. But in terms of the anti-inflammatories, they can actually worsen the symptoms of heart failure, but they themselves usually don't cause the heart failure, but they can affect the kidney function. And when the kidney function is poor, that can lead to heart dysfunction. So it's very complex, but I do think at the very least, you're right, it can exacerbate or kind of worsen the symptoms of heart failure. They usually don't cause it themselves. You usually need something else to cause the heart failure, and then they can just kind of make symptoms worse. So, if you're taking those medications and you don't have heart failure, you follow up with your prescriber or your healthcare professional, and they will check and make sure you're having good kidney function and things like that. But usually that would be rare for it to cause heart failure, but it just will make the symptoms flare.
Gotcha. Yeah, that's great. Thank you for clarifying that. Does Excedrin fall in that same category with the other anti-inflammatories?
Excedrin falls in that same category here.
Great, thank you. Could you describe what AFib is and what relationship it has to heart failure?
So AFib is another electrical abnormality of the heart. That's where the top heart chambers, instead of being a conduit or where blood flows from the top to the bottom, there's some of the blood is also squeezed and pumped into the bottom chamber. When we lose that squeeze and the electrical activity is basically going haywire, that is AFib. The top chambers are fibrillating. They're basically not squeezing, they're just kind of shaking. And that itself, if the atrial fibrillation, AFib, is going very fast, that can lead to heart failure just from the heart rate being fast, or what we call tachycardia. The heart doesn't like to go fast for a long period of time. So we do not uncommonly see heart failure from atrial fibrillation. It is an electrical disorder that can lead to heart failure. It also puts people at higher risk for stroke, but it is an electrical abnormality in the top heart chambers.
Perfect. Thank you for that. Can heart failure lead to a heart attack, or what's the relationship between the two?
The thing that we worry about with heart failure is people dying suddenly. So we don't call that a heart attack, but we do call that, sudden heart death or sudden death due to the heart stopping, or the heart can have a dangerous rhythm from the bottom chambers that can lead to the heart stopping. That is the worry. When the heart becomes so weak, the heart now is at risk for very dangerous rhythms, and those dangerous rhythms can lead to sudden death. That is different than a heart attack, is when the blood in one of the heart arteries stops. It gets so narrow that there's a blood clot inside of that vessel or that artery, and that leads to a heart attack. But heart failure doesn't usually cause heart attacks. Heart attacks can lead to heart failure, but the thing that we worry about is when the heart is very weak and can lead to sudden death. And that's why it's so important to diagnose it and to treat it, because of that risk for sudden death when the heart becomes so weak.
Great. Thank you for that explanation. Let's take one more question here, and then let's make sure we have some time to get into the next part of the presentation. So you talked a bit about the different symptoms of heart failure. Is it possible to have no symptoms and still have heart failure, or to have a heart attack with no symptoms?
That's an excellent question. So some of this is semantics. So heart failure, by definition, you have symptoms. It is a syndrome, and that syndrome is characterized by those symptoms that I mentioned on the previous slide. If you can have risk factors for heart failure. And risk factors means that the heart has changed its structure. The heart is weaker, but if you don't have symptoms, you don't have heart failure. So that's where you'll see the term cardiomyopathy. You may have issues with a weak heart. You may have a thick heart. You may have changes to the heart chambers and large heart. But if you don't have any symptoms, then you do not have heart failure. But you do have something that places you at high risk for heart failure. So heart failure itself is characterized by symptoms. If you don't have symptoms, you don't have heart failure. But you can have risk factors for heart failure, and those risk factors can be actually a weak heart muscle, a prior heart attack, AFib. You may have those risk factors without the symptoms of heart failure.
Perfect. Thank you for that. Let's go ahead and pause here with the questions and get into our second part of the presentation, and then we'll come back for some more at the end.
Excellent. Okay.
Thanks.
So, how do we diagnose and test for heart failure? So, we really just touched on that. So, it is a syndrome that is characterized by some symptoms, some set of symptoms. And we mentioned that common symptoms would be shortness of breath, difficulty breathing, it will be tiredness, and fluid buildup. Those are three of the main symptoms. So just by talking to your healthcare professional, your physician, your doctor, your primary doctor, your cardiologist, we can use what you tell us and get some of that history and some of your symptoms. And we can also examine. So we use our stethoscope, we use our hands, we use our eyes to see if there's any fluid. We that combination is really all that you need to make the diagnosis, or most of what you need to make the diagnosis. So we can make the diagnosis of heart failure just by what you tell us and what we do in terms of our physical examination. Now, some of the subsequent tests, such as blood tests, such as an electrocardiogram, which is also known as an EKG or ECG, and an echocardiogram, can further help tell us what type or tell us the cause. But again, just by listening to somebody's symptoms and performing a physical examination, that can give us majority of the information in terms of trying to figure out heart failure. So most doctors and healthcare professionals, such as nurse practitioners, physician assistants, are very used to making that diagnosis of heart failure. But some of the subsequent tests, that's where additional tests will help confirm or give us more additional information to say, is it from a stiff heart or is it from a weak heart muscle? That's where the echocardiogram comes in. Even the electrocardiogram, the EKG, will help us with the heart rhythm. So it can tell us about the AFib, as the one questioner asked about AFib. We would diagnose that based off of our physical examination, but also the electrocardiogram. Same thing with the bundle branch block. A chest x-ray can show us if there's fluid buildup in the lungs. It can also look at the heart and just tell us if the heart is enlarged. A cardiac catheterization, these are tests to look at the heart arteries or measure the pressures around the heart. And then there's other tests such as a CT scan of the arteries of the heart to look for narrowing. A nuclear test, those are also known as stress tests. That can also, we do that to look for blockages. And MRIs of the heart can be another useful test to give us more information about what the heart structure is and trying to identify the cause of the heart. Again, identifying the cause is very helpful, and that can lead to a very specialized and specific treatment in addition to some of the normal treatment that we will prescribe for most patients. This is a picture of a EKG. This is a normal looking EKG. So this is, people may have had EKGs done before. This gives us a lot of information about the electrical activity of the heart. We're not going to go through all the intricacies of EKG. I just wanted everybody to see what I meant by EKG. And, these spikes are the energy and electrical activity of the different heart chambers. The first spike is for the top chambers, and then this second narrow and larger one is for the bottom chambers. And this is showing when the heart is contracting and then when the heart is relaxing. So that's what an EKG is. This is a picture or one clip of an echocardiogram. This is kind of the heart, like the picture, the animation that we showed. We're just kind of looking at the heart sliced in half, and we're seeing the main heart chamber, which is that left ventricle, the bottom chamber, and that's pumping blood through the aorta into the rest of the body. You don't see the blood on here, but the blood would be in this black area. So this is a picture of what an echocardiogram. That's also an ultrasound of the heart. So we're using sound waves to generate pictures of the heart. So that gives us a lot of information. It can look at the heart valves. It gives us information when you're dealing with a heart murmur. That's one of our very important tests when we're trying to diagnose the cause of a heart failure. So what are some of the things you can do to prevent heart failure? So we'll see the same theme, and I've mentioned this before when discussing high blood pressure, but lifestyle. So you can do a lot. Healthy eating habits. We said the most two common causes of heart failure in our country is from coronary artery disease or narrowing of the heart arteries, as well as high blood pressure. And both of those are preventable. So it goes back to a healthy lifestyle, healthy eating habits, physical activity and exercise. So getting the heart rate up and being able to do 150 minutes per week of moderate exercise has been proven to help prevent high blood pressure, and that in turn can prevent heart failure. That in turn can help prevent coronary artery disease or heart artery narrowing. Maintaining a healthy weight, avoiding and limiting alcohol, as well as quitting smoking. These are all things that we know can help prevent heart failure. Excuse me. Treatment. Again, treatment, the same things that we mentioned for prevention are the same things that we encourage for treatment, lifestyle changes. So that same physical activity, healthy eating, maintaining a healthy weight. We also add in the lower salt intake and fluid restriction. Our diet in America has very heavily dependent on salt. So there's a lot of sodium or salt in our diet. And if you eat out at a restaurant, you'll probably take in 2 days worth of salt intake based off recommendations. And when you have a weak heart or when you have a stiff heart, the heart cannot handle that extra fluid. And salt attracts fluid. So when you're drinking a lot of water, when you're eating very salty foods, this can lead to additional fluid that the heart can't pump. And in turn, that fluid will just stay in your body. It will go in your legs. It will go in your lungs, and that will make you feel bad and lead to additional symptoms of shortness of breath or worsening symptoms of shortness of breath, I should say. A mainstay of medications. And again, I'm mostly referring to that weak muscle, the systolic heart failure. There's been several groups of medications or classes of medications that has been proven to improve survival and, prevent that sudden death due to a heart rhythm issue or the heart stopping suddenly. It also helps to decrease hospital visits, strengthen the heart. That's also a possibility. And then we have medications that help people feel better. Those are medicines that help get rid of extra fluid or excess fluid. Some people, depending on their cause of heart failure, may require additional cardiac or heart procedures, as well as devices. Some of these devices are pacemakers. Others could be heart valve devices, things that we want to help people feel better, live longer. When heart failure is very, very progressed or very severe, there are mechanical devices that we can put in, artificial pumps that can help serve as the heart pump for you. Those are done only at very specialized centers. Um, One example is called an LVAD. There's also surgery, which one of the last options would be a heart transplant. In some cases, we refer people for those. And again, Those types of devices and that type of surgery is done at very specialized centers. If the heart failure is from a heart valve issue, then we recommend treating that heart valve. And most of the time, that requires some type of surgery or procedure to replace or repair the heart valve. So, again, this goes back to what is the cause? Based off the cause, we try to fix or we try to treat the cause so that there are better outcomes when you treat the cause. What are the role of cardiologists? So cardiologists such as myself who see heart failure and treat heart failure every day, we focus on prevention. So when people are seeing us and they have high cholesterol or high blood pressure, we treat them knowing that we're trying to prevent not just, heart artery narrowing, which is coronary artery disease, but we're treating their blood pressure. We're treating all the things that you may not feel a difference so that we prevent things such as heart failure later down the line. So prevention is key. You may not feel better right away because high blood pressure, like I mentioned last year, we call it the silent killer. But we have seen a lot of patients come in who have dealt with high blood pressure for 20 years untreated, and now they have congestive heart failure, and that is preventable. We help with the diagnosis. Again, we help with the treatment, the monitoring, and some of the procedures such as atrial fibrillation. We can do procedures where we shock the heart back into normal rhythm. We put you to sleep and then we shock the heart back into normal rhythm, which hopefully will then lead to better heart function, as well as different devices and referrals as mentioned in the previous slide. We are a part, we're just one part of the treatment team, though. Heart failure is really about teamwork. And what I didn't include in the slide is the patient themselves. So you are part of the treatment team. So patients, cardiologists, we work very closely with nurse practitioners and physician assistants. We work closely with nurses and pharmacists, social workers, and physical therapists. It is a team approach, and that team approach is designed to help you feel better, live longer, and to prevent things as well, prevent complications or prevent sudden cardiac death, sudden heart death. And speaking of treatment team, we also have a specialized heart failure center here at St. Agnes. And here's a picture of some of our members, part of that team. And they work closely with us cardiologists. They work closely with your primary care doctor and managing heart failure. They really do a great job with education, controlling symptoms, and getting you on the right doses of some of those medications where doses actually do matter. So we have done a lot of research in the heart failure realm. And when I say we, I mean in the medical community, and shown that proper doses, getting people to good doses of some of these specialized medications can really have a great impact. So our heart failure team, they do an amazing job here, and we work very closely with them. And they, like I mentioned, we have dietitians. We have access to cardiac rehab. They really help with monitoring. We have scales that we give out so that you can monitor your weight, and they do a good job of educating and preventing hospitalizations as well. So heart failure is really a team approach. And here at St. Agnes, we value that team approach. So we're going to open it up for additional Q&A at this point.
Excellent. Thank you, Dr. Uqdah. That was a great presentation and a lot of good information. And we have a lot of questions. So let's go ahead and jump in. Um, will nebulizer treatments help a patient's breathing during heart failure?
So that's a good question. Sometimes you will hear wheezing from heart failure, and that wheezing is less from the lungs, but more from the fluid that can basically build up around the lungs, and that can lead to wheezing. Usually in that situation, nebulizers won't help. If it's from heart failure and from the weak heart muscle, the nebulizers may not help. The nebulizers help open up the lungs, and that's the airways. So that's usually more for asthma or COPD. But if it's truly wheezing from heart failure, then nebulizers will not work.
Okay, great. We've got a couple questions relating to stents. Can you describe a little bit how a stent works and how it's used in the treatment of heart failure?
Yes, stents, that is a mainstay for coronary artery disease or when you have a heart attack. A stent basically is a metal scaffold, like a small gate that is used to open up the artery. We use a balloon on the end of a catheter to open up the artery, and then a stent helps keep that artery open because after you use a balloon to open up the artery, it can collapse back again. So we put a stent in, which is basically a metal scaffold to keep a narrow artery open. And that treats coronary artery disease, which in turn can lead to heart failure. So that doesn't treat heart failure directly, but it treats one of the most common causes of heart failure, which is coronary artery disease. So stents tend to be the mainstay for narrow or blocked arteries, especially in when people have heart attacks and they come in with a heart attack, or when we find through some of our other tests and narrowing of the arteries, we can put in stents to help people feel better. But also, if it's a lot of blockages, a lot of narrowing, that can also improve the heart function, which would be heart failure in that case. So indirectly, stents can help improve heart failure, but it's really through the artery disease and fixing arteries that are narrow.
Okay. So if you have a stent put in, is there does that last the rest of your life, or do you need to get like stents put back in periodically? Or like if there's another failure somewhere else, would you go back in for the same kind of procedure?
So yeah, so usually stents, once we put them in, we don't remove them, and they can last a lifetime. We have patients that have stents in from 25 years ago. We don't periodically go and put in more stents, but we let some of our other testing or symptoms drive if people need a new stent. So we can put a stent on top of another stent or a layer on another stent to if you needed another stent in the same location. Um, Testing such as stress testing, such as cardiac catheterizations, they're all driven by symptoms. So if you have a heart attack and you had a stent placed and now you have no chest pain, your heart function has improved, we don't usually just go and say, oh, let's do another heart catheterization because of the risks that come with that without a just cause. So usually they can last a lifetime. We will know if they need to be, if something else needs to be done, such as another stent, because it's symptom driven and driven based off certain tests depending on your situation.
Okay, great. And last, I think stent question. Are stents used to help treat carotid artery blockage?
So stents, there's surgery for carotid artery blockages where our vascular colleagues will go in and clean out the artery. And there are stents for the carotid artery too, but they're you it's best to have a conversation with your vascular specialist, which in some cases are cardiologists, or we have vascular surgeons that typically do the surgery, cleaning out the artery, or the stents. So that's usually a conversation of which one will have the better outcome and which one will have the least amount of complications. But stents have been developed for the carotid arteries.
Okay, perfect. Thank you. Um, if a person were diagnosed with a stiff heart, what would you do to improve your symptoms?
So yes, stiff heart. We diuretics help stiff heart, so removing some of the fluid. There are now newer medications that we use even for the systolic or the weak heart that have been proven to help on the stiff heart. There are medications that have made or contribute to making the heart more relaxed. And that's the mainstay treatment. We also try to figure out why the heart is stiff. Is it stiff because of years of high blood pressure? Is it stiff from obesity and diabetes? Is it stiff because of it's an abnormal protein that has now invaded or attached to the heart muscle? So we try to figure out the why, but there are now um, one a few different classes of medications that can help improve that stiffness.
Great, thank you. How is COPD and emphysema related to chronic heart failure?
COPD and emphysema are other conditions that can uh, decrease the amount of oxygen or lower oxygen in your body. So that can lead to additional symptoms of shortness of breath. And, the heart needs oxygen too. So sometimes that can worsen your symptoms overall, just of difficulty breathing. So there are two different conditions that can both lead to shortness of breath, and sometimes it can be difficult to distinguish one from the other in terms of a flare. But there are certain tests and certain things that we can do to try to help with that. But they're two separate entities that can both lead to difficulty breathing, and one may affect the other.
Okay, great. We've got a couple questions related to blood pressure. Are there certain heart conditions that specifically affect the diastolic pressure?
Certain heart conditions.
Mhm.
There are certain heart conditions that can affect the diastolic pressure, certain conditions that can affect the systolic, and some of those conditions can lead to higher systolic blood pressure. Certain conditions can lead to a lower diastolic blood pressure, and some of these conditions are related to heart valve issues. Um, High blood pressure, both is important in terms of both the systolic and diastolic. So if you're asking, is there one versus the other, like high blood pressure, the diastolic, if that's higher, is that going to cause more heart failure? I think we treat both of those equally, meaning that we want to make sure both are within normal range.
Okay, thank you. And another blood pressure related question. The recommended blood pressure is 120 over 80. Is there an issue if if your blood pressure is consistently 120 over 50? And is that potentially related to any heart failure concerns?
Yeah, the newest goal or guidelines say less than 120 over 80 would be normal blood pressure. And 120 over 50, it really depends. I think that question depends on the age of the patient, if they have other medical conditions. Sometimes taking numbers out of context can be a bit tricky, but if somebody feels well, they have no symptoms, and they have no lightheadedness, no shortness of breath, that can be their normal range. We have patients that have blood pressures of 100s over 60s or 100s over 50s, and they feel perfectly fine. But I think that really depends on some of the other conditions or other treatments that people are on. So that in of itself, I would say just the number by itself doesn't mean that it's abnormal, but it needs to be put in context.
Okay, perfect. And just a quick note, I see we've had a couple of hands raised in the chat here, and unfortunately, we don't have a connection to allow audience members to speak on the webinar tonight. So please do put your questions in the Q&A box there so we can make sure we get to you. Um, okay, and then one other blood pressure related question. So
Okay.
you had mentioned a little bit earlier about meds for systolic pressure. Are there particular meds targeted for diastolic pressure?
No, no, the medications that we use for high blood pressure or hypertension treat both.
Okay. Okay. Thank you for clarifying. Okay. Um, has there been any correlation between COVID and heart disease or heart failure?
Yeah, that there has been. So when I mentioned inflammation and during the peak of COVID, we would see, some interesting situations of blood clots that we weren't typically seeing. And some of those blood clots would be in very unusual places, like in the heart arteries. But I think there was a lot of press with COVID and inflammation, and in turn, that inflammation leading to heart failure or weakened heart muscle. We haven't seen as much as that since the early stages of COVID. And actually, when you look at the grand scheme of things, I think there was discussion about vaccination versus COVID. COVID itself can lead to a condition of inflammation. COVID is a virus. So when I had up, viruses can affect the heart. COVID is one of those viruses that can affect the heart and lead to inflammation of the heart, which in turn can lead to heart failure.
Okay.
And, I would have patients ask about, well, is that possible with the vaccine? And it's possible, but it's much more, when you compare it to, more common for COVID, the virus itself, to cause the heart failure more than the risk from the vaccine.
Okay, thank you for that. And kind of along the same vein, you mentioned like inflammation. I'm guessing inflammation of like heart tissue.
Heart tissue, the heart muscle. So that inflammation, um, when we typically talk about that, we're talking about heart muscle inflammation. There can be inflammation of a more rare condition of the arteries of the heart. But when we speak about inflammation, yes, I'm referring to the heart muscle.
Okay. And this is kind of a general question. I'm not sure if the asker is asking about specifically heart muscle, but the question is, does chronic inflammation affect the heart? So I'm guessing it's probably general inflammation. Um,
Like
but
maybe inflammation in other parts of the body. So there are disorders where people have general inflammation, such as rheumatoid arthritis, for example. Um, those patients have a higher risk of having inflammation in the heart compared to the general population, but it doesn't mean that they're going to have heart failure from that inflammation. But it is, I mean, that's one of the reasons why you want to get that inflammatory or inflammation condition treated. The inflammation also can lead to heart artery narrowing, again, which can lead to coronary artery disease, which in turn can lead to heart failure. So, yes, those disorders are known to have some effects on the heart, but it doesn't mean that you will have heart failure or inflammation of the heart just because you have those disorders. But it does come with a higher risk. Those are risk factors for congestive heart failure and for coronary artery disease.
okay. This next question is related to heartburn. So in the past, a person has had symptoms of heartburn before they discovered that they had heart disease as well. So how can you tell the difference between a heartburn or indigestion versus heart failure symptoms?
Indigestion, heartburn is usually a sensation of, right, discomfort in the chest, and that can be difficult to differentiate between, I would say, coronary artery disease or narrowing of the heart arteries more than congestive heart failure. Remember, more congestive heart failure is more about shortness of breath, weight gain, fluid retention, whereas heartburn is more of a symptom of chest discomfort. But it can be a bit difficult to discern, is that heartburn coming from the acid reflux, or is it coming from the heart? And, I do think when you're dealing with that, there are certain signs, or if we see that people have a lot of risk factors for coronary artery disease, or it's happening only when you're exerting yourself, those are clues for us to do more testing to make sure it's not from the heart arteries or the heart itself, the narrowing. But definitely, I think seeing a healthcare provider, seeing a primary doctor, seeing a cardiologist can help differentiate between the two. But it's more heartburn versus uh, coronary artery disease and less heartburn versus congestive heart failure or heart failure.
Okay. And related to that, telling difference between like a heartburn episode and if it's a heart attack versus a heart fit, like heartburn rather than a heart attack.
Right. Sometimes it is difficult. And if a patient already has, I would say for people that have had a heart event and that heart event was similar to the heartburn that they're having, they should treat that like the previous episode, and they should, go to their nearest emergency department, call 911 if your symptoms are similar to a heart attack. If this is the first time having those symptoms, again, severe symptoms, you should play it safe and be evaluated at a emergency or a specialized center that will evaluate you for chest discomfort and heartburn because the severity, other signs may be important, but you need somebody to kind of help uh, tease out those other aspects of the discomfort.
Okay, great. Thanks. That's a good distinction. Um, let's see. So if heart failure and stroke runs in the family, for example, a father or a mother, um,
Mhm.
is it recommended to have your children checked? And if so, at what ages and what kind of checks would it be recommended?
Yeah, my general recommendation is if it we handle these two different ways. For people that heart failure runs in the family, for example, I'll focus on a heart failure rather than a stroke because that's probably best answered by a stroke specialist. But in terms of the heart failure, if you have had heart failure, you're diagnosed at a certain age, and you were tested and you have identified the gene or the DNA responsible for that, then your first degree relatives should all be tested. And they can undergo the same genetic testing, which is usually a swab, a cheek swab, to see if that gene abnormality is present. If somebody does not test positive for the gene or they are not tested at all with the swab, then we generally recommend, depending on the age of diagnosis, we will recommend adults to get echocardiograms every so often depending on the age of their family's onset and, depending on the age of the patient or the relative. So it can be basically if somebody has symptoms, that's a different story. You go and you see your medical professionals, your primary care cardiologist. If you don't have symptoms, then we generally will screen with an echocardiogram. And based off that condition or based off the age of your relative, you may get an echocardiogram every 1 to 2 years, and that can kind of change over the years to more like 3 to 5, and it also depends on the condition.
Perfect. Thank you. Is there any blood work that's usually ordered when treating chronic heart failure?
Yeah, yep. We use blood work as a way to help look for some of the causes because some of the causes can be identified through blood testing, whether it's inflammation in the body, whether it's abnormal protein in the body. But we also use that to check kidney function to see if remember, if the heart is not pumping effectively or efficiently, some of the things that can lead to is organ dysfunction, and some of the organs would be kidney dysfunction. And we can monitor kidney and liver dysfunction or function by measuring blood tests. There's also certain tests that can help give us prognosis or kind of help tell us or give us additional information. So we can do that. So there's testing that we do, and it all depends on what type of heart failure and what stage you're in of the heart failure. But yes, that's a very common aspect of the diagnosis and treatment plan and monitoring.
Okay, great. Thank you. Can heart failure be diagnosed, or like a heart attack be diagnosed at years after the event? So it sounds like heart failure is probably an ongoing thing, but like heart attack specifically, is that something that you can kind of go back and say, yes, that episode was in fact a heart attack?
Sometimes we try to piece that together like a puzzle. And if somebody told me, oh, you know, 3 weeks ago, I had a severe episode of chest discomfort. And then 3 weeks later, now they have symptoms of congestive heart failure. And then we do certain tests and we see that there was an artery that is now blocked 100%. I can then feel confident that, yes, 3 weeks ago, that was probably a heart attack you experienced. And now you have congestive heart failure from that heart attack. So, yes, but that is not always the case. But yes, we can make temporal relationships and put together some missing pieces to fill in the gaps.
Perfect. Are there any vein issues that affect the heart or could lead to heart failure?
Vein issues. So, yes, those would be more rare things in terms of sometimes we can be born with abnormal connections to some of the veins that connect to the heart chambers. Those are not as common as the artery issues. The answer is yes, that's possible, but rare and uncommon.
Okay. While being on a heart monitor for non-cardiac related care, my doctor noticed irregular heartbeats. Is this something that we picked up by an EKG or EKC? And are there other ways for a cardiologist to recognize symptoms?
So, can you repeat that question one more time, Kelly?
Yes. So while being on a heart monitor for non-cardiac related care, their doctor noticed irregular heartbeats. Is this something that would be picked up by an EKG or EKC?
Yeah, so an EKG is a one time, we look at the electrical activity of the heart in different views, like the picture I showed, the illustration. A heart monitor can do that, but not, it will just look at it in one or two views. A heart monitor can pick up what we call early heartbeats or skip beats. It really depends on what that rhythm issue is. We do know that if you have a lot of those skip beats from the bottom chamber, that it can be associated with weak heart muscle. And in those situations, we will order an echocardiogram and order some other tests to try to see what the heart function is. But an EKG or ECG, yes, can pick up some of those heart rhythm issues. It really depends on when they're occurring. So the advantage of a heart monitor is we can do it and we can order or place a heart monitor that can stay on for 2 weeks up to a month. There's other longer term monitors that we can do through a procedure that's more invasive that can stay in and monitor people for up to 3 years. So yes, we can pick up those things on EKGs, ECGs, but it really depends on what they were seeing on that heart monitor. But we know that heart rhythm issues can be a risk factor for um, heart failure.
Right. Why is sleep apnea a risk for heart failure, and how does a person know if they have sleep apnea?
That's a good segue from the question before. So, sleep apnea is a condition that, when we say obstructive sleep apnea, when people go to sleep, their upper airway, so the neck muscles, kind of collapses, and it prevents people from getting oxygen while they're asleep. Well, the heart is very dependent on oxygen. So if the heart is not getting oxygen, that can actually lead to the heart rhythm issue from the prior question, irregular heartbeats or AFib. And then in turn, those issues can then lead to heart failure. So it's kind of like that 2 or 3 step process where one condition can predispose to another condition, and that condition is now a known cause or risk factor for heart failure. Symptoms of sleep apnea, a lot of times you depend on people around you that observe your sleep, but not having restful sleep. So when you wake up, you're still tired, feeling headaches throughout the day, feeling tired even though you got a good 8 hours of rest. Your loved ones or people observing you um, snoring or difficulty breathing or stop breathing while you're asleep. These are all symptoms and signs of obstructive sleep apnea. To make that diagnosis, you need to see your primary care doctor or a sleep specialist or even cardiologist. We order sleep studies because it can be related to other heart conditions. We don't primarily treat sleep apnea, but it's a common condition. And people that are overweight or have a lot of neck muscle or excess tissue are at risk for that condition. And it can lead to high blood pressure. We have patients that they have sleep apnea, they get treated, they get a mask that puts pressure around the face and opens up the airway when you're asleep, and that has helped with blood pressure management without medications. Very common condition.
And kind of along those lines, is there a particular sleeping position that helps with heart failure or heart disease, like sleeping on your left or right side versus more upright? Is there a recommendation from that perspective?
There's no specific recommendation for that in terms of to improve, heart failure itself. The biggest thing is we use that as a sign of if somebody's having worsening or a heart failure flare. So if my patient can generally sleep flat or on one pillow, but then if they come in and say, now I need to prop myself up just to feel good, just to not have trouble breathing, I'm sleeping upright, or I'm sleeping in a recliner, or now I need 5 pillows. It's really a tip off, a sign that the heart failure is becoming more active.
Fantastic. I know we're a little bit past the 8 o'clock hour here, and we still have so many great questions in the chat. I am afraid we are not going to be able to get to all of them tonight, unfortunately. So I just kind of want to do a recap here. So we have a few questions asking for reminders about the signs of heart failure. So Dr. Uqdah, could you just give a quick recap of, what things to be watching out for when it comes to heart failure?
Absolutely. So, heart failure, some of the cardinal or some of the main symptoms would be shortness of breath, especially with activity or when lying down, feeling weak or tired, which is a complaint that people have for a lot of conditions. So if it's just that without the shortness of breath or without the weight gain or swelling, that does not mean it's heart failure. It can be other conditions, like we mentioned, sleep apnea, like anemia, low blood counts, things like that. But when you combine that with weight gain from fluid buildup, swelling in the feet, ankles, and legs, these, when you put all of those in coffin, nausea and lack of appetite. These are the common symptoms collectively that may signal that you have congestive or heart failure.
Thank you very much for that. And then just Dr. Uqdah, if we could just quickly talk through kind of if a patient were to have these symptoms and they're wondering kind of where to start on this journey, would you recommend going to see their primary care first? Do they need a referral to just come see a cardiologist, or how does that process work?
Yeah, I would say, sometimes shortness of breath can be a lot of different things. And if you have a diagnosis of heart failure, you certainly will need to see a cardiologist in most instances, and that's usually done via a referral from your primary care doctor. Some people, their insurance does not require a referral, but most insurances do require a referral. So the first step is usually seeing your primary care provider, who again will be very astute at making that diagnosis of heart failure. Again, I mentioned before, a lot of healthcare professionals are very good at making that diagnosis just based off what you tell them and what they observe or what they find on examination. If you have confirmed heart failure or you have a family history of heart failure and you want to discuss that more, you want to discuss other testing because of your family and first degree relatives, we also can help with that too. So I think for most people, we do say you see your primary care doctor first because of the usual typical need for a referral, but also because your primary care doctors are very good at, teasing out what the diagnosis is. And they also do a good job at connecting patients with specialists such as myself and cardiologists.
Fantastic. Well, thank you for all that great information, and thank you everyone for all of your great questions. I wish we could get to all of them, but that I think we would be here for a long time. Um, so if you do have additional questions or concerns that you want to reach out to the office about, this is the number for Dr. Uqdah's practice, Ascension St. Agnes Heart Care, on your screen. That's 410-644-5111. And we'd be happy to answer any questions you have, or you can also find more information on ascension.org.